We have begun. All right. So we're going to continue our discussion on bone, and this is the 6B. This is really the physiology of it today. So on the board, that's hormonal controls, the chemical controls that involve the calcium aspect of it, and we're going to take a look at growth, and we'll see if maybe with any good fortune we'll get into fractures and go from there. So that's the sort of the agenda for the day, as it were. So some of the stuff is eminently skippable, but this is the interesting part. We begin to see bone very, very, very early on. Okay, and with the luxury today of ultrasound, we can do a lot of identification. But you can see it begins to start early on in development, and again, growth of bone continues into early adulthood. And this particular author is going to tell you about that girls generally by 16 or 18, effectively they've reached, and I would say it's closer to 16 than 18, bone, completion of bone growth. Boys are in that 18 to 21. There's a lot of historical basis, anecdotal basis, meaning there's a lot of individuals who have grown substantially after, even in their early years in college for males that are there. So all of that, and again, I've said it any number of times, the remodeling and repair is a continuous process, all based on usage, and obviously other factors are involved as well. Really, our focus point is about whether it's this stuff and fibrous membranes, and again, it all comes from hyaline cartilage, with the exception of what's called intramembranous bone. So that's N or endochondral. Both, I've seen both the terms. Bone forms by replacing hyaline cartilage. That's the cartilage. Bones are called cartilage bones for most of the skeleton. I never called them that. Okay, intramembranous, very limited. You're talking about your clavicles and some of the major bones in the skull. That's about it. And why they form one way and not from a cartilaginous eye, I've never read any articles, scholarly articles, to identify that are there. So all bones inferior to the base of the skull except the clavicles, okay, enchondral or endochondral ossification. Relatively late in development, about a month two. Previously formed hyaline cartilage models, and something called in the center of the shaft. And the pictures tell the story. This is not a big deal, this stuff. You should get used to if you're listening to these recordings or here in class, when I'm going through stuff relatively rapidly, it's not vital. If you're going to know it's important because you can hear me, this is a skill that you will acquire the longer you are in an academic setting. You'll be able to discern, even if it's something that you have a class that you really is not anything you're even familiar with, you'll be able to tell. Teachers, we can't help ourselves. We give it away. It's impossible to teach without giving it away. Trust me. All these years of experience. So primary ossification center, enchondral bone is important. Blood vessels infiltrate. Again, that sheath is the perichondrium. It's going to become the periosteum. And as soon as blood vessels get it, that's the secret sauce. Okay? Blood vessels, once they begin to invade anything associated with cartilage, it magically starts to change to bone. Effectively, it changes almost immediately. Okay? And here the mesenchymal cells are these magical cells that can be fibroblasts, chondroblasts, or osteoblasts. And then they go through all these things. There's a bone collar, central cartilage that calcifies, periosteal budding, blah, blah, blah. No, not there. The fact that it elongates and begins to form the cavity, that's important. And then we begin to see, and you'll see it illustrated better than I can explain to you, secondary centers. That's another area, a separate and distinct blood supply that begins to affect the ends of the bones, which we call the epiphyses. Okay? And then obviously they start to ossify. And when all the cartilage is left, you did joints already with Dr. You didn't do joints? Is that today? Never. And I'm responsible for all the joint stuff. I can handle it. I It was one of my favorite areas to teach. Really. Okay. So hyaline cartilage is all that's left, and that's when we'll talk about that in joints. How did I know? These are the pictures. So here, what's it showing? We start with this. There's effectively in the primary ossification center, it really just starts to develop very early on. We really almost simultaneously with the input of this, which becomes the main blood supply to the diaphysis or shaft of the bone. And then, of course, we see the medullary cavity begin to form. And you begin to see the differences in bone. And then with secondary sites, we call secondary ossification or forming bone centers. And voila, what do we have here? Those are called epiphyseal plates or growth plates. Those are important terms. That is, you'll come to know that is in growing bone, that is the structural weak point. See, that's a test question. The inflection of my voice, tapping the table, see me looking at you rather than looking at this. Little clues like this should help you going forward in your academic career. Hey, intramembranous, I don't even understand how it works. Magically, fibrous connective tissue formed from mesenchymal cells makes these wonderful bones. I'll buy it. Okay? When a cluster become osteoblasts, osteoid is secreted, woven bone forms. The lamellar bone places the woven bone and red bone marrow. Imagine lovely pictures. I'll buy it. Okay, so intramembranous ossification is just to know that there it is. Maybe there's one question. I'll even make sure that I don't even remember it, but I'll get to it. And now we get to these two types of growth. We have appositional growth and interstitial growth. We have it in cartilage and we have it in bone. Interstitial elongation. That's the part that basically stops when we effectively our maturity, our bone maturity is reached. We utilize that in orthopedics. Interestingly enough, we can almost try to we can actually make bone grow if we want to. And that's a very interesting way. I'll give you, it's a mini anecdote down the road. Bone increases thickness through appositional growth. That's shape. So if you're in a weight-bearing job, it's going to shift. It's going to make it thicker on particular sides. You're going to be versus a non-weight-bearing job. If you use your upper extremities a great deal, lifting and moving things, it's going to change it there. So the shaping of the bone, and surely part of maturation, shaping of the bone, the final, because the bones are relatively indistinctive until those forces, that Wolff's Law thing, begins to change their shape. The trochanters aren't that remarkable, and all of a sudden they become very, very remarkable as things start to pull. And you saw how large those guys are on the femur. That's the advantage of the larger bones, the extremity bones. The markings are fairly distinctive that are there. Some facial bones and people's face will change. Other things that occur in bone that appear like it's growing are really more like extremities change a little. Hands and feet, sometimes they begin to spread out a little bit more. You maybe see some thickening, sometimes associated with arthritic changes. There's different things that occur that can involve, but it's really not so much bone growth per se, unless we're dealing with fractures, and we're going to have a whole unit of fractures. This is the part, there is a couple of significant things here. This is about how they elongate. And I'm even going to show you the exact area that is the structural weak point. Typically, when a child has a broken bone and they have epiphyseal plates that are open, a growth plate that's open, this is where the fracture is. It's going to be there in some way, shape, or form. There's variations. Presence of epiphyseal cartilage, growing cartilage, that's there at what we call the plate. That remains constant, okay? So the cartilage grows on one side and it's balanced by bone replacement on the other. Okay, where the cartilage is by itself, we call it the quiescent or quiet zone, relatively inactive. And then it begins to change. It's almost imagined that the plate is being pushed farther and farther and farther away. It's laying down bone toward the shaft, and effectively the ends are moving farther. Think of it that way. So an area of the proliferation zone on the diaphyseal side means toward the middle of the shaft. So you get any kind of illustration, generic. And the growth plate is here, typically about there. The bone is being laid down here toward the medulla, toward the center of the shaft. Effectively, the epiphysis, and the same thing's on the other side, being pushed farther. That's how it works. So, the area of cartilage on the diaphyseal side of the epiphyseal plate is divided. New cells move upward, pushing the epiphyses away from the diaphysis. What happens, the ones that are closer to the shaft begin to thicken. What happens is that middle portion of the shaft already has blood supply. Again, as it gets close to blood supply, it changes. And effectively, it's dying. The cartilage is dying. It's going to be replaced by bone. That's the easiest way to remember. And what happens to anything is it begins to thicken and it begins to undergo changes that we would classify as degenerative. Calcium, when things are damaged in the body, they attract calcium. Calcium's everywhere all the time. Bones tremendously filled with it. So that anything that is damaged, we see this all the time. When people get hardening of the arteries, which you talk about more in cardiovascular and AP2, one of the highlights of an artery that's really severely damaged is we see it on an x-ray, we see calcification. At that point, school's kind of out for that particular blood vessel. It's probably not going to get better. Maybe you have to bypass it, maybe you have to do something extraordinary with it. But I think the meaning I'm trying to get you, when we see damage, we see calcification. Sometimes muscles that are badly damaged will get calcification. So that's a sign of deterioration. Deteriorated tissue attracts calcium. So it begins to calcify. The chondrocytes die, and they deteriorate. And then, leaves long little spicules of this calcified cartilage close to that junction point, and magically they become bone. That's really that's called ossification. So when you look at it like this, the critical area. So here, easily recognizable. This is the distal aspect of the femur. This is the proximal aspect of the tibia. Why is that not a fracture when it's nice and smooth and not irregular? And if you're not sure, we compare it to the other side. And if they look the same on both sides, well, Junior's knee is hurting, and you take it, maybe you heard it in sports, and you look on both sides, if it looks identical, then probably it wasn't a fracture. That's the diagnostic aspect. And so that's where, and it's a difficult thing. I'm not asking you, I'm not going to show you or print on a test x-rays and have you make a diagnosis. Please don't look. I didn't even do that with the advanced class. We'll answer, what kind of fracture has more than 2 fracture lines. We're going to get to that. So here you can take a look at a photomicrograph. Here you can look at the diagram. This is it. So here's the growth plate. Here, as it begins to enlarge, it's probably because inadvertently the blood supply from below is having an impact. It hypertrophies. You can see how the cells enlarge. When they enlarge, the enlargement is predisposing them to break down. Here they begin to calcify. The structural weak point, everybody write this down, listen to this, underline it. The structural weak point of growing bone, of the structural weak point of the epiphyseal plate, is the zone of calcification. Calcifying cartilage is the structural weak point in the growth plate. That's even specifically where it hurts. Are you listening there in the back? Everybody writing that down. Good to see it. Trying to wake everybody up. So near the end of adolescence, everything slows down, the plate thins, and it closes. somewhere in this sequence, they talk about an epiphyseal line. I've never seen one on a bone. Never. Oh, there's an epiphyseal line where the growth plate was. Doesn't exist in real life. I can tell you how many bones I've operated on. I have yet to see one of those guys. That understand there's a difference between an anatomist in whether teaching in undergraduate or graduate or medical school versus a clinician, someone who's actually seeing it different. Different terminology. I mean, you learned about movement. They talk about medial. Did you learn about medial and lateral rotation yet? Okay, how things move, right? Like rolling your legs to the inside or rolling your legs to the outside. That's called, an anatomist is called medial and lateral rotation. Orthopedic surgeon calls it internal and external. Different terms are used clinically than are used, trust me. And wherever you work, if you're going to be in a clinical field, you get used to the terminology. And the terminology you'll encounter are the people you work with, because the different doctors, the different nurses, they've all gone different schools. And mostly the doctors they'll use terminology that you have to get used to. And that's what they train with. Same thing with me. So what you're hearing from me may be totally different than when you go into a workplace setting. And just apologize, tell them that blank, who was teaching me anatomy and physiology, is 2 years older than God. It's okay. Blame me. So when the epiphyses fuse, okay, I'll buy it. Females, I think it's more 16 to 18, closer to 18. Males around 21. To understand growth in males, okay, I didn't tell you this. Famous basketball player that when Pitt was in its heyday in the 80s, they got the coach from Navy. The coach from Navy had this player. He was on the first championship team with the San Antonio Spurs. Okay, and his name was David Robinson. They called him the Admiral. 7'1" center. When he matriculated at the Naval Academy, he was a 6'4" point guard. His first summer, he grew 9 inches. And interesting, he still had the skills of a point guard. He only served a couple years in the Navy because just ships you can't get through the doors. You're too big, really. It's just not designed that way. If you've ever been on an actual naval vessel, the doors are not that big. And you have to you have to dog every, you know what I mean? So everybody understands. So boys can have late growth. My 2 nephews both had that kind of spurs. Growing bones widen as they lengthen through appositional growth throughout lifetime. Different stressors. The more stress that's on them, what they do is the bone balances itself out. When there's more pressure on it, it gets thicker. When it's bending more, it gets thinner. You'll see that. And then those osteoclasts are able, and it's a constant. The bone is still there, proportionally speaking. You have the same amount of bone, but where it's under stress and being compressed to resist compressive forces, it thickens, and it's weakening on the outside. Thinning would be a better word. To be able to bend more. Weakening is probably a poor term to describe for that. Usually more building up than breaking down, which leads to thicker, stronger bone that is not too heavy. Okay? And so they're trying to show it to you here. Okay? You'll get the thickness on one side, you'll get the thinness on the other side. And I don't get a lot out of this, but that's the way we can actually look radiographically, which means looking at an X-ray and easily determine, maybe handedness, that type of thing. Certain occupations will be predisposed to that. So there's a lot that can be gleaned from looking at this. That's really the big deal about growth. I'm not going to ask you to remember all the zones per se. I do want you to remember where we begin to see that zone of where the cartilage is forming. In that particular zone, that's really the structural weak point within the growth plate. Have an idea when the growth plate's closed. Okay. Hormonal regulation. This is all about calcium. You see it up here already? Turn the light on. Everybody, close your eyes. Here's calcium control. Number one, hit parade. It's a giant bank for calcium. Parathyroid hormone. His job into the parathyroid gland. You can't do it out. Endocrine burn that. Thyroid, you can remove. You can give something. Parathyroid hormone. We use the abbreviation PTH. See more of that when you get to endocrine. The whole idea of that, when it is active, calcium levels fall in the bloodstream. Parathyroid hormone gets a signal. We've got to pull stuff out of bone. That's where those osteocytes come in. So what it does in bone, it begins to activate those osteoclasts, osteocytes, they begin to break down the bone, and it will elevate calcium in the bloodstream. And it's the main control. Probably the most active site. It also sends a signal to the gut, GI tract. In the gut, it works in concert with vitamin D. They have to work together to absorb and breaking down. The gut, they work to absorb calcium, and obviously that's going to increase calcium in the bloodstream also. And in the kidney, parathyroid hormone tells the kidney to retain, not excrete, not worry about calcium. Therefore, that will elevate calcium. The oddball, so vitamin D is something that we get, but I don't get it from diet. It's activated by a variety of things. It's activating your kidneys, it's activating your skin. Probably when you do the skin unit, hopefully you learn that you have to have direct sunlight exposure to activate vitamin D. That's one of the reasons. And not standing by the window. Got to be out in the sunlight 20 minutes every day. Calcitonin, which is made by, interestingly, the thyroid, not very much of it. This is the one that increases calcium in bone, not the bloodstream. Notice that. In doing so, it decreases calcium in the bloodstream. The only one that lowers. We do not know precisely its role in adults. It's very active in growing bone. Sure. When we get to the osteoporosis part of the program, that's when we'll talk a little bit more. I mean, they're trying to use calcitonin or similar things for maybe to treat osteoporosis. It's very, very difficult. Osteoporosis is a really complex problem. We spend a little bit of time to remember the roles of these. This will help you when you get down to when you get an endocrine and digital. Again, the role, and that's why with the thyroid, you can supplement thyroid hormone, and the calcitonin is not such a big player, as far as we understand. But when it comes to parathyroid, calcium is just unbelievably vital. As you will see, every part, as you're going to start seeing when we finish with bone and apparently joints, that now I'm doing. Just going to do arthritis, but it's okay. I can take the hit. Then the next unit, and you'll just love that. Did you do muscles? You're doing those now? When are you going to get the nervous system? Next week? Okay, so he's getting all that stuff in. Dissecting your brain? When was that? Okay. God bless all of you for putting up with this. That's why I'm being nice. Because it was not easy. I mean, it is not, there's a very difficult thing. And I think it's implicit that we have to give you guys the opportunity to demonstrate yourself. My wife said this, I didn't. I'm tinkering. Remember, I was talking about that, the thing I'm doing with the tests. For everybody, if you weren't here, would you hear about with the tests? 10%, 30, 30, 30, if it helps you. She said, why don't you just tell them you're going to drop the worst grade, no matter where it is? Maybe I'll do that. Don't thank me. It's her idea. And when I heard that, I was taken aback. I said, really? And she goes, do it. And you know how I respond to her? No, yes, dear. She can't talk to me like that. I know how to respond. Yes, dear. Right away, dear. Because I have lived this long. The same. So that's kind of going to be, so I'm going to put that plan in. I'll probably have to. Oh, potential spam is calling me. I love that. Potential spam. And I didn't get them anything. Moving on. So growth hormone, yes, very important. It's active all the time. So I mean, you should mention that for the sake of completeness, but particularly in growing bone. Not that growth hormone goes away because it never does, but it's particularly active in infancy and childhood. You're going to learn when you get, and this is endocrine stuff, when you get into endocrine, thyroid is everything. Thyroid basically plays a role in all activities. It's like your body's engine. If your body's engine, if you start the car in the morning and it hums, then your thyroid is fine. If you have one of those, like my 150,000 as of today miles on my old VW, that's hypothyroid. And if you have one of the old days, we used to have muscle cars for my boys, vroom, vroom, the monster engine, that's hyperthyroid. So basically, it governs the rate of your body activities. So it's impactful whether it's reproduction, whether it's the endocrine system, whether it's cardiovascular, whether it's muscle physiology. You want the thyroid to always be there. So thankfully, if people don't have enough or too much, we have supplements or medications that will work for a long period of time. That's why the thyroid, as important as it is not effectively essential. So I mean, it modulates activity of growth hormone and every other system. These are interesting. Most of the time, those classic reproductive hormones, testosterone and estrogens, at puberty are what make growth spurts. We see growth spurts are funny in little kids. Okay, you can usually tell they start to eat more, and the next thing you know, like this. But there's a pre-adolescent and adolescent growth spurt. There's a lot of variations, and when they are really, and why one will cause growth plate closure at an early age or at a later age is unclear. I was this height. I wasn't this height. I was a little bit taller. In ninth grade, stopped. What are you gonna do? And then you have irregularities. They're classic to look at. You look at them in endocrine, giantism, dwarfism, variety of different terms that are associated with it, whether it happens before or after growth plate closure. There's a very interesting disease called acromegaly that's part of it. So here, these are the numbers. 5 to 10% of bone mass is recycled each year. Spongy bone every 3 to 4 years. Compact bone every 10 years. Good stuff. That's why, unless there's been gross, it's and a young person who breaks a bone and doesn't require surgery and it just heals in a normal fashion, you can't necessarily, after a year or so, you can't tell what. And then it goes, and we'll look at bone healing with fractures after we look at our fracture unit. So bone remodeling, deposit, and resorption occurs at the end osteal surfaces, okay? Inside osteoblasts and osteoclasts respond to signals from hormones and stress-sensing osteocytes. So I mean, I don't get a whole big deal out of this. Really, it's a give and take. If we have to break it down, the osteoclasts, and the signals will go. If we have to build more to reinforce an area, it's the osteoblasts. All I really want. And then this is really to understand how the osteoclasts work. And again, whenever you see the suffix clast or clasis, the implication is some type of destruction, some type of a destructive force. It breaks something down. So they break down the matrix. They secrete, okay? They use acidity and they use enzymes. Remember lysosomes from the cell, digestion and defense. These are the digestive part, okay? The chemical, and I certainly would not ask you about this, but it was something I would ask my advanced physiology students down the road. Typically, we look for enzymes that are called phosphatases. Depending on where it is, and we look for alkaline or acid phosphatase. So you don't have to know it, but I'm trying to give you an idea. Some of these enzymes are there. In this case, acidity assists the process that is there, and they dissolve everything. Understand that it's not just leaching out the calcium salts. Dissolved minerals are transported across transcytosis, mean they make their way through the cell. They don't get interacted by the osteoclast, chop up dead osteocytes, and then they're done. Okay, they have a lifespan. We're constantly replacing them. Okay. The other thing to understand, when they are effectively a modified white blood cells, they don't last forever. Blood cells have a lifespan. When you get to the blood unit, you're going to learn some white blood cells, it's very, very short. Some it's a bit longer. But red blood cells, 90 to 120 days. Platelets, we're constantly recycling things. So it's a notion that a lot of times people in your early days looking at life sciences have to understand it's not, there's not a sense of permanency. Yeah, I'll buy it. You got one heart, one brain. So those are structures that are irreplaceable, literally and figuratively, in the sense that we can't make more of those cells. And so again, that word apoptosis, when resorption is complete, we just make more. Okay, and I don't do the osteoid seam or the calcification front. So it binds calcium ion. Here you can see, this is where they like the alkaline phos don't have to do this, don't have to do this, don't have to do this. Okay, any of that stuff. The big word to remember out of this, see, I'm trying to make it so you don't have to, maybe part of the mistake was I should have been more clear about telling you, this is me looking in the mirror, about telling you what's not on. Okay? And it's a fair criticism. Help me, work with me. When you're done with lab, I don't want to hear it. All the time in the world. So voila, hydroxyapatite crystals. Here's the hormonal controls. It's all negative feedback. Yeah, different forces, mechanical and gravitational. Those are the big things. Again, that's Wolff's law. If you somebody in one of those international space stations for 6 months with weightlessness, their bones are going to thin out, not permanently, but surely when they come back to Earth, or however they get back, however they're transported back, they're going to have to be careful. And I'm sure that that's part of the process of reacquainting them. I thought it was acclimatization, but I think you get the idea. Okay, to what they have to do. Calcium is so important. Nerves can't fire, muscles can't contract, blood can't clot, There's an endless string of the vital importance of calcium. 99% of the 1,200 to 1,400 grams, what's that? 2.5 pounds or so, 3 pounds of calcium in bone. Intestinally, must have vitamin D. That's the critical role of vitamin D in bone. Short course. Start, and again, I'll reinforce it at the end of this chapter. When it comes to vitamin D, you want to be on the high end, not the low end. Fat-soluble vitamins, A, D, E, and K, you can have too much of. Water-soluble vitamins, it would be hard to have too much of. You could conceivably really overdid it, but basically we urinate them out. That's what makes them water-soluble. As long as your kidneys work, and get rid of it. D is one of those interesting ones where there's a lot of studies going forward, not just for osteoporosis, breast cancer and prostate cancer. two monstrous glandular cancers have more vitamin D. I take vitamin D supplements not just because of being older. It's a good thing. Okay. Easy to find, easy, tiny little pills. The only problem is if you have to have surgery, it's a little bit different. So parathyroid hormone, parathyroid glands, at the low blood levels, they increase it. They stimulate the osteoclasts. The calcium goes into the blood goes up. Negative feedback 101. Set point. If it's altered and it goes too low, we got to get some more. If it goes too high, we'll turn around and do less of it. Put it back in the bone. Okay, calcitonin thyroid. Don't worry about the cells. That may be whoever's going to teach you AP2 in response to high levels of that. Effects are negligible, but at high pharmacological doses, it can lower blood calcium levels. That's the interesting part. It's probably they're referring to adults, I think, more than anything else. And I think that's why it's used in osteoporosis therapy. We've had a very difficult time, we, medical science, speaking collectively, not me, trying to be able to find a, quote, magical medicine to treat osteoporosis. It's just not there. So even minute changes. So, and I'm not going to ask you about, but it gives you an idea of the importance of calcium. Low levels, hyperexcitability. High levels, non-responsiveness. I mean, in general, you're going to see it. It depends on whether it's affecting muscle or nerve. And potassium do the same thing. You're going to see low levels of potassium, arrhythmias in the heart, irregular beats. High levels can really slow down function. There's so many things. And that's what we're going to get into when we start looking at nerve and muscle. Sustained high blood calcium levels can lead to calcium salts. So I talk about in blood levels, or in the kidneys, or stones. Big problem. So if you're going to take calcium supplement, the right calcium supplement to take is calcium carbonate. So a lot of women take Tums, that's calcium carbonate. Usually, old days we used to call it Oscal, which was oyster shell calcium. Most of the time, or Caltrate. Most of the time, they come with vitamin D already to facilitate your absorption, your diet. So I think all of that is relevant. Calcium is funny that way. Calcium doesn't just go to injured tissue. When you have excess calcium, it will start to, it's a fancy term you don't have to know, when it's called metastatic calcification, meaning that it can just start to deposit anywhere when it's excessive. And the other one, damaged tissue, is a little bit different. That's not at your pay grade just yet. Depends on where. Here's the calcitonin, thyroid, effects. Again, whoever wrote the PowerPoint thinks they're negligible. Okay, there's all sorts of other hormones impacted, and I'm just reading it to you. Part I want you to know is it's much more effective in growing bone at putting the calcium into the bone. It helps bones grow because it takes the calcium from the bloodstream and puts them into the bone. And that's it. Here's Wolff's Law. Weight bearing on them or muscles pull on them, grow, remodel, and lifetime. So the compression, the shaft thickens where it's being bending and it's being compressed. It thins, relatively speaking, on the outside. And the tension, and they cancel out each other. The classic example, you with that wonderful neck of the femur. Okay, all of your torso is sitting on this. You could imagine this better be thicker, and to compensate, okay, we're going to have to allow this to bend, so it has to be a little bit thinner. So compression here, tension, stretching there, it adapts appropriately. There's so many, mechanically speaking, for the students in here doing, like, you're going to do biomechanics or biomedical engineering. If you're going to work with extremities and weight bearing and sport, all of this you have to take into account. The whole idea of what we call kinesiology, all those things. I have a fairly decent background in this, so it's been a long time. So handedness. Curved bones are thickest where they're most likely to buckle. All that bone, the funny thing is, it's still a stressor. And so we look even for stress fractures in and around that area. Okay. So, there's limitations to everything. And then weightlifters. These big, that you see, when we see skeleton, greater trochanters, medial epicondyles, really distinctive bony prominences and a lot of stuff attached to it. If you see their skeleton or you look radiographically, those are big. And you can discern what they did. Forensically, that's important too. When they discover a skeleton, they don't know what it is. You know, a cold case, maybe it was accidental, maybe it was intentional. All those types of things. Those are clinical clues that allow pathologists and crime solvers. I love that stuff. My wife throws things at me every time I watch a new crime show. I'm addicted to British crime shows. They love mysteries. The Agatha Christie thing. And this is what happens. Beetle bones, which really aren't even there, bedridden people, lack of stressors, they call that atrophy, an important one. So this is another interesting little nugget I should inform you about. And it started at the University of Pennsylvania, the Hospital University of Pennsylvania in Philly, called electronic bone healing. This came into vogue, meaning it started to be used in the late 60s. We did some of it. I had some of it with my patients. Effectively, we use electrical current. When bones were healing too slowly, they would actually incorporate in a cast or in a removable device, okay, like two plates, and a plug would protrude, and you'd have to have the patient plugged like when they're sleeping for 8 to 12 hours or rest. And what happens is, remember charged particles, the flow of the charged particles you could direct to the area where the fracture was. And so I know a lot of times that was used for fractures that you suspected were going to be slow healing or had already become slow healing, and you had to do some things later to avoid the fact that they would not heal, because those are big problems. Okay, pushes fluid containing ions, charged particles, through the little canaliculi, okay, detect the current and release chemical messengers and promote formation. So the science is clear, and it's called electronic bone healing. And then obviously there's hormonal aspects of it, determine whether and when remodeling occurs. Blood calcium plays a role in that, stressors, all of that stuff. So that's mostly contextual. I'm not going to ask you about electronic bone healing, but the point I want you to get out of all this, it's a very sophisticated, well-understood mechanism for a lot of these things. I think that's important. So I will introduce briefly our next topic. What we'll get into on Friday is this. We're almost done with this chapter. There's not a whole lot less. We'll surely finish it on Monday. But the misconception about broken bones, another one of the things I've treated a lot of, is people, the uneducated, oh, they go to the emergency room. Oh, they said I didn't have a fracture. I just have a tiny crack. Or they go see, well, I looked at your x-rays, there's a little chip. Don't worry about it. It's not really a fracture. Pardon me. My grandfather used to say, donkey dust. That's bullshit. Sorry. If there's a break if there's a discontinuity in the integrity of the bone, an interruption in the integrity of the bone, it is a fracture. Period. End of sentence. Don't judge it. We'll get into what happens, why fractures occur. But this misconception, if bone is broken, it's broken, whether you can see it or not. And a lot of times you don't see them. A lot of times we treat them as a fracture if we can't see it, and we rely on an x-ray 10 to 14 days later. You make people go broke if you're going to MRI and scan everything. Understand there's a limitation for those things. If you've got what looks to be a broken finger, they don't need an MRI or a CT. And by the way, CTs are better because they're really just computerized x-rays as opposed to magnetic resonance imaging, MRI, which is much better for soft tissue, just as a general aside. Okay, and this is very true. In young folks, it's accidents, trauma, it's sports, it's whatever. Just that's typically what we see. Okay, in older people, changes in the bone. Osteoporosis is one of them. Cancer invading it would be another. It's not limited to those issues as well. Other bone diseases and bone problems can manifest, or immune system disorders. So when we see fractures like that, we call them pathological fractures. Some disease entity, not necessarily trauma or accident. So you have fractures, and you don't want to paint with a broad brush. Okay, they can still happen, and fortunately, youthful bones have damage. Sometimes it's related. It can be dietarily related. There's other factors that are involved. I mean, unfortunately, this is sad. When we see childhood cancers and things like that can have an impact on that. All of these are part of it. In the old age, absolutely. By far and away, the thing we see most of the time are what are called compression fractures, the bone almost collapsing on itself. That hip that you saw before, typically in a hip fracture, the hip, it isn't, oh, grandma fell and her hip broke. The hip breaks because it can't support her weight. It cracks at that neck, down they go, and now there's a hip fracture. And where it cracks in the neck is very significant. I do a whole unit on that in lab. It's just fun for me because I have a lot of experience with it. Okay, and I'll get into the fracture classifications. I do not want to start this, but we'll start here on Friday. Thank you very much. So I'd rather do it that way. Stopping.